So I'm a pharmacist and a researcher. In my clinical world, I've worked primarily in geriatrics and long-term care specifically. So statin use and kind of statin deprescribing is something I've come across a lot and thought about a lot, and I'm still continuing to think about it more, as I'll kind of get to. That's what I'm going to be talking about today: statin deprescribing for older adults. My declarations are up here on this slide. I don't have any relationships with commercial interests. I receive an honoraria for writing a deprescribing column for a pharmacy magazine, and then I have grant money for research related to deprescribing. And then my salary comes from UBC and my clinical pharmacy work. Something I'll also mention is, as a kind of a relevant disclosure, that I co-lead an initiative called deprescribing.org, and we're obviously all about deprescribing, and I'm a member of the Therapeutics Initiative as well. Our group at deprescribing.org is actually working on a statin deprescribing guideline right now, and that work is supported by Health Canada through our colleagues at the Canadian Medication Appropriateness and Deprescribing Network. So I'm not talking about the guideline today, but just I think it's relevant to declare that kind of I'm working in this space and kind of have kind of skin in the game here. And today, what I hope that you'll take away is kind of an understanding of the evidence around statin deprescribing for older adults, and hopefully an ability to apply some of that evidence to individual patients in practice. I think really as this is kind of a best evidence webinar, my focus really is on the evidence and kind of looking at that, but we will of course talk about kind of practically speaking what that kind of means for individual patients. And probably not shocking anyone here to talk about what statins are, but they're medications that are used to reduce risk of cardiovascular events. They do this in a few different ways, but really kind of the aim is kind of reducing cardiovascular risk in the end. And we know that they tend to be used in two different situations. The first is in what we call primary prevention, which is when someone has no history of cardiovascular disease. And then we also have secondary prevention, where we're trying to reduce the risk of another cardiovascular event from happening. And we know that in secondary prevention, this group is at higher risk of an event happening in the future compared to primary prevention. And for those of us who are practicing clinically and caring for older adults, again, probably not shocking that almost half of older adults were taking statins in Canada as of 2016, according to CIHI data. And it's also relevant to mention that discontinuation of statins for older adults is also pretty common. So if you look at population-based studies over a few years, around 1 in 5 people discontinue statin therapy. So just to say that it's a decision or an issue that actually comes up pretty commonly in practice. So it's relevant to obviously have the discussion about evidence like we are today. And so in kind of the clinical life of caring for older adults, there are a lot of different situations that come about where people are taking statins. And so I put a few different situations up here, and we'll kind of talk about relevant evidence when it comes to kind of each of these situations today. And really the central kind of question we're asking with these kind of clinical situations is, should we continue a statin, or should we think about maybe stopping a statin or having that discussion? And of course, that is essentially what deprescribing is that conversation about continuing or stopping a medication. And we know that typically we're thinking about deprescribing when a medication might no longer be necessary, or when the harms of a medication might outweigh the benefits, or in the situation where a medication does not necessarily align with someone's goals of care or what matters most to them. And when we think about the decision to continue a statin or discontinue a statin. A lot of people jump to kind of evidence or lack thereof around starting statins in older adults. And I'm probably, again, not shocking anyone when I talk about some of this evidence, but we know that most of the clinical trials that involved starting statins were done in younger people and included very few people over the age of 75 years of age. And so we know that there's very little evidence about starting statins in people over 75. And what evidence we do have in this population includes primarily people between the ages of 75 to 80. And it doesn't include people that have a lot of chronic health problems or frailty. Those people were excluded from trials. And then when we think about primary prevention in particular, what evidence does exist is conflicting. So if you look at the most recent cholesterol treatment collaboration meta-analysis, which is that Lancet reference at the bottom of the slide there, there's no benefit for statins in reducing cardiovascular events for primary prevention when started in people over the age of 75. But then we know in secondary prevention, there is evidence that there's a benefit of starting statins in this age group. But again, those trials did tend to exclude more kind of frail patients. And if you want to kind of read more about that, the Therapeutics Initiative has done a lot of work about initiating statins in people over the age of 70 or 75. And so, yeah, a lot of people conflate lack of evidence around starting statins as ammunition for stopping statins. But of course, the issue that tends to come up, at least in my clinical work with older adults, is, okay, you're sitting with a person who's been on a statin already for 20 years. So it may have been started when they were 66, but now, they're looking quite different at age 86. And maybe now they take, 15 medications and they have a lot of chronic health problems. So it's not a question about, do we start a statin in that 86-year-old? It's about whether to continue a statin that some person's been taking for 20 years ago. And I think that brings about the question, does lack of evidence around starting a statin in an 86-year-old mean a statin should be stopped? And I don't profess to know the answer to that question, but I think there's increasingly kind of a suggestion that stopping a statin is not the same as not starting one in the first place. And that lack of evidence around starting statins in people 75 years of age or older is not necessarily a reason to stop statins. So this has been explored quite a bit in a recent commentary that's open access in the Journal of the American Geriatric Society, and it kind of dives deeper into that. And so I don't think we can completely ignore the evidence around statin initiation because it's certainly relevant. But today, I just want to talk more directly about evidence on statin discontinuation. That's really kind of the focus of today. But I just thought I would briefly talk about kind of the initiation evidence because it is relevant. And so if we're sitting with an older patient, reviewing their medications, and we see they're taking a statin, and we're kind of thinking, could we talk about maybe stopping this statin? First place we might look is clinical practice guidelines. So I'm just going to quickly summarize kind of what guidelines tend to say on this topic. And the Canadian dyslipidemia guidelines don't really provide any specific advice for persons over the age of 75. And then similarly, you can see in the middle there is the US Preventive Services Task Force guideline who don't make a recommendation at all in people 76 years of age or older. So there's not really much help there. And then you have other guidelines, American guidelines, who do provide some recommendations about this. So they're saying that it's reasonable to continue statins in people 75 years of age or older if statins are tolerated. And then it may be reasonable to stop in certain situations. So the American guidelines do comment on this in particular. And then there's also from the American College of Cardiology an expert consensus decision pathway, which is not exactly a guideline. It's kind of just expert opinion. But in my view, it's pretty practical and I think useful in making decisions about any cardiovascular therapy in people with multimorbidity So it's also free open access to read. And I think again, it's quite useful. And they kind of look a little bit deeper at kind of different kind of clinical scenarios or clinical pictures of older adults and how decisions might be made in these particular patients. And I'm not going to get into the nitty gritty of it, but just to say that, this kind of piece of guidance goes a little bit deeper in helping to make decisions around cardiovascular therapies in older adults. And then another Canadian guideline, which came out very recently, does also comment on statin therapy amongst older adults. And they recommend, this is the peer guideline, which was just published in Canadian Family Physician and is free to access. And this guideline says in patients that are already taking a statin and tolerating it, they would recommend against stopping or reducing the dose purely because of age. And just as an aside, they also say don't start statins for people over the age of 75 for primary prevention for most patients. So thought I would just kind of quickly summarize these guidelines and what they say on the topic. But I guess the challenge is that looking at those kind of expert opinion documents and the recommendations that are made, they really, again, are inferred from the indirect evidence around initiation of statins. But they don't really consider the evidence on statin discontinuation. And I think looking more at direct evidence on statin discontinuation is helpful to inform decisions. And so that's what I'm going to do today. And this is my kind of interpretation and thoughts on some of the different evidence that exists. So as always, very interested to hear what other people's interpretations are, what questions they have, how they're kind of approaching this in practice. So this is just kind of my look and my summary of the evidence. And so it comes as no surprise that there's tremendous heterogeneity amongst older adults. And so as I kind of alluded to earlier with different clinical situations, people have different pathways of ending up on statins. And so over the next few slides, I'm just going to go over how available evidence specifically on discontinuation of statins might apply in some of these different scenarios. And the first one to look at is the first one, and that's a 90-year-old person with dementia who's newly admitted to long-term care and has been on statins for 12 years and is now at a point where they're taking 12 medications and have cognitive impairment and need assistance for function. So are probably considered to be moderately frail with limited life expectancy. And so we're kind of thinking about this kind of clinical picture in this type of patient. And for patients like this, there is relevant randomized controlled trial evidence. So there's a randomized controlled trial from 2015, which was conducted amongst people with a life expectancy of less than 1 year. And that included a mixture of people with cancer and other end stages diseases. And in this trial, people were randomized to continue taking statins or to stop statins. And when we say people with an advanced life-limiting illness, this was based on physician response to the surprise question. And if you don't know what the surprise question is, it's, would you be surprised if this patient died in the next 12 months? Which, as people who are familiar with it are probably aware, it's not perfect by any means, but just to say that is how kind of limited life expectancy, life-limiting illness was described in this particular trial. And so these authors looked at a few different outcomes. The primary outcome was mortality, and it ended up being mortality at 60 days, which is they had to change partway through the trial because people were surviving longer than they anticipated. But it was 60-day mortality, and the authors found no statistical difference in mortality between the groups. As you can see, the median time to death was also quite similar. If you look at the absolute difference, there maybe was numerically a higher rate of 60-day mortality in the statin discontinuation group, but again, the median time to death was actually longer in the discontinuation group. And then in terms of cardiovascular mortality, there was no statistical difference across 1 year of the trial in terms of cardiovascular mortality. So considering the trial design and kind of some of the outcomes, there's probably no difference in 60-day mortality or cardiovascular mortality in people with a life expectancy less than 1 year based on this trial. And the authors also looked at quality of life outcomes using the McGill Quality of Life Questionnaire. And they found in the overall score, there was a statistically significant difference in quality of life, but we're kind of less certain about this outcome, because this trial was not blinded. So people knew that their statins were discontinued, and the clinical relevance of any quality of life difference is unclear. There was also a trend towards taking fewer medications in the discontinuation group, which is not surprising because people stopped taking statins. So some of these kind of patient-reported outcomes, there may be kind of a favorable effect from discontinuation of statins, but kind of less certain than for the more hard endpoints of mortality and cardiovascular events. So thinking strictly about the evidence here, the authors conclude that stopping statins is probably safe in people near end of life, and there might be benefits in terms of reducing pill burden and improving quality of life there. So this is, particularly in kind of that end of life population. And then we can look at other situations where people might be taking statins and have been on them for many years. And what does the evidence say about statin discontinuation in those patients? So the next thing we might think about is a relatively healthy kind of 79-year-old who's taking a statin for primary prevention. Again, they may have been on a statin for 8 years, but are very independent, living with their spouse, walking the dog every morning. So overall, relatively healthy older person, and we're thinking about, okay, should we continue a statin in a patient that looks like this? And I'll stop right now and say there's no randomized controlled trials that address this question, which is probably not surprising. However, there are a number of observational studies, mostly cohort studies, and we're doing a systematic review on this. And there's around 35 cohort studies that kind of address statin discontinuation. But before we kind of get into the actual evidence, I just want to talk a little bit about the approach of using a cohort study to address this type of question and what some of the advantages and disadvantages of that might be. So these cohort studies that I'm going to talk about are basically trying to mimic a randomized controlled trial. And they do that using routinely collected data about prescription medication filling. So if you're from British Columbia, they are using data that's collected from PharmaNet, for example, and then linking that data with information about hospitalizations and death, which is also routinely collected. And so the idea is to identify some baseline date where you have a large group of people who you are pretty sure are taking statins based on the pharmacy data. And then you kind of follow them over time, and you can look at the pharmacy data and identify when someone's not filling their prescription anymore. And if they stop filling their prescription, you might think that they've stopped taking their statin, and so you could call them a discontinuer. And then if you have people who you can see are continuing to keep taking their statin, you would obviously consider them a statin continuer. And then you follow those two groups, and you can see what happens to them, and then compare in each of these groups, was there any difference in outcomes like cardiovascular events or mortality? So that's kind of the idea that these cohort studies are using. And it seems like a pretty good approach to studying the effects of statin discontinuation. You mimic a trial. Certainly an advantage is that you have large samples, as you'll see, that are many of them are population-based studies, so they're representative of the population. But there are some important weaknesses which impact how much we can trust any of this observational evidence. And a major one is that you're relying on prescription filling data to judge whether someone stops a statin. So firstly, you don't know why the person stopped taking it. Was it a conversation between their primary care physician where there was an agreement to stop the statins, so deprescribing? Or did someone stop taking it on their own? Why did they stop taking it on their own if they did? Did the person just fill their prescription really irregularly? And so and then ultimately, were those reasons different between the groups? They may be. We have no way of knowing. Another challenge that you don't know exactly when the statin was stopped, because all you're relying on is the last date the prescription was filled. And that can kind of make it difficult to know the timing between stopping a statin and any kind of risk of an event. So these cohort studies use different techniques to try to balance the groups at baseline to make sure they're similar, but they can only do that based on the data that's available to them. And then the other major challenge is that statins might be stopped because people are in poor health. And then people that are in poor health may also be at higher risk of adverse outcomes compared to those who continue statins. And how can you capture that? And that's something that's called, in this case, confounding by indication. And it's really hard to adjust for kind of poor health using routinely collected data. So the bottom line is that it's really hard in these studies to know exactly how comparable the two groups are to each other. And that kind of affects how much we trust the results. And so it's kind of a long preamble into the evidence, but just want us to think about that as we're kind of looking at these studies, to just kind of take them with a grain of salt. And so back to the evidence. Statin discontinuation in primary prevention. So this is a cohort study which was conducted in France. The sample size is around 120,000 people. And these are people that turned 75 years of age, and they were on a statin for primary prevention. And so this is obviously a bit of a younger old cohort. And if you look at the characteristics of the people in this study, they were kind of a healthier cohort. And the authors looked at people who discontinued statins and compared them to people who continued statins over a period of about 2.5 years. And the main thing they were looking at was risk of hospital admission for a cardiovascular event. And so this curve in the top left of the slide, the gray line shows the incidence of cardiovascular events in people whose statins were discontinued. And then the black or the darker curve at the bottom shows the incidence of cardiovascular events in people who continued statins. And so the authors report around a 30% relative increase in hospital admissions for cardiovascular events. And then they do provide an absolute risk using an adjusted absolute incidence of events. And so the absolute risk increase in events was around 2.5%. And so we can translate that to, there's about 1 excess cardiovascular event for every 40 people who discontinue statins over a 2.5-year period in this study. So overall, there might be an association between statin discontinuation and an increased risk of cardiovascular events, though this study, again, comes with all of those considerations we talked about with cohort studies kind of in this space, but there's suggestion that maybe there's something there. The other situation is the one that probably gives us the most pause clinically, I would say, and that's a person who's been taking a statin for 10 years for primary prevention, but now has multiple comorbidities, is potentially considered mildly frail and is experiencing polypharmacy. So we might be wondering about available evidence in this space. And there are a couple of more cohort studies which kind of address a slightly older and more complex group of older adults. And so the first study is one that was conducted in Italy, and it's, again, another population-based cohort study, around 30,000 people in this study. And it was an older population. And the criteria for being included in this study was that a person had to be taking at least 4 medications. And the authors provide a comorbidity score at baseline for all people captured in the study. And around 1/3 of the cohort had a moderate or higher comorbidity score. So we can conclude that probably they're older and a little bit more complex than in the previous study. And again, they looked at people who discontinued statins and compared them to people who continued statins over a period of around 2.5 years. And there were more outcomes investigated in this trial. So I'm just going to put up a plot here of their results. And so the authors found that statin discontinuation was associated with an increased risk of the composite of cardiovascular outcomes. And that's kind of the 4th outcome down in that plot. And then there was also a higher risk of all-cause mortality in the discontinuation group as well. Then for some of the events, there was a trend towards a higher rate of events in the discontinuation group, but that was not statistically significant, as you can see. So when we're looking at ischemic heart disease hospitalizations, for example, or cerebrovascular disease hospitalizations, there was not a statistically significant difference in the rate of those outcomes. And the authors analyzed both primary prevention and secondary prevention together, but then they conducted some sub-analyses and they looked at their findings according to primary versus secondary prevention, biological sex, age, and then comorbidity status. And they found that there was no difference in their findings based on these different factors. And so the conclusion here is, again, there may be an association between statin discontinuation and risk of fatal and non-fatal cardiovascular outcomes. But again, same cautions that we had with the previous study that we looked at. And so the final study that we're going to look at is this study, which was conducted in Denmark. And this was, again, a large population-based cohort, 95,000 people. In this study, there was a separate analysis for primary and secondary prevention. And again, it was a slightly older cohort, and there was more medical complexity in this cohort. For example, around 70% of people in the primary prevention cohort were on 5 or more medications, around 80% in the secondary prevention cohort. So again, a little bit more complex. And the follow-up in this study was longer, it was around 5 years. And again, we're looking at discontinuation compared to continuation of statins. And the primary outcome in this study was a composite of major adverse cardiovascular events, or MACE, as you can see on the slide. And that was a composite of hospitalization for stroke, cardiovascular death, or hospitalization for heart attack. Similar to the previous studies, there's a relative increase in risk of cardiovascular events associated with statin discontinuation. And as you can see in both figures, this was true in both primary and secondary prevention. And then the absolute risk was provided in this study as well. And you can see the absolute risk increase for statin discontinuation was around 1% per year. So this translates to around 1 extra event per 100 discontinuers. And as you can see on the slide, the absolute risk was a little bit higher in secondary prevention, which is not surprising, given that the baseline risk is a bit higher in this group. And again, the same kind of limitations apply in this evidence to the other cohort studies we saw. So just to generally sum up evidence from some of these cohort studies, I only highlighted 3 studies, but as I mentioned, there's actually quite a few more. But consistently with these studies, there is the suggestion that statins might be associated with an increased risk of adverse outcomes. And as I alluded to, because of the limitations, we're still very uncertain about whether we can trust these findings. One thing I can confidently say is that more cohort studies are not going to resolve any of this uncertainty. And then the other thing I would say is that these cohort studies still don't get at whether kind of frailty or polypharmacy or multimorbidity actually influences that association that shows an increased risk of cardiovascular events with statin discontinuation. And from two of the trials that tried to separate, or from two of the studies that tried to look at primary versus secondary prevention, there's not a suggestion that it matters, although it may affect the baseline risk, or sorry, the absolute risk, but overall there's not an understanding of whether the indication for statins kind of influences this association. So, and the evidence is of course one piece of decision making, but also want to come back to think about why we might be considering deprescribing in the first place. And that's particularly kind of the last bullet there, which is looking at when a medication might no longer fit with a person's healthcare goals, treatment preferences, or just what matters most to them. And so, as usual, when we're considering the evidence that I just talked about, it's being applied to individual patients, and that includes that discussion of what matters most to patients, what their healthcare goals are. When we think about, some of the effect estimates and the absolute risk measures that I showed in some of those cohort trials, which are, very crude and we're very uncertain about them, what is the interpretation of that level of risk when we're kind of applying it to an individual patient? So all that to say is there's not necessarily one right decision when it comes to statin deprescribing, just like there's not one right decision when it comes to starting statins. It's really about that conversation to find out what makes sense to an individual patient given all of the factors that we're talking about. And I mention this because there has been examination into kind of patient preferences around statin deprescribing and how do patients feel about it? Do they want to talk about it? And so I'll just briefly summarize that to kind of add some context to the clinical evidence. And there's an open access systematic review which has been done on this topic and published last year, which is looking at barriers and facilitators to deprescribing cardiovascular medications. And this, for those who are kind of having these conversations and seeing patients clinically in this space, probably is not shocking, and it kind of probably reaffirms what you see. But most patients are going to be concerned about a cardiovascular event happening in the future, and the qualitative evidence kind of supports that. So patients are concerned about future cardiovascular events. But then, that's kind of balanced against things like taking a lot of pills, how a person interprets the benefit-harm balance of stopping a statin. And so many patients are not bothered by taking many pills or taking a statin, but others are going to be motivated to reduce the number of pills that they take. Some people are not as impressed with the kind of potential benefits of statins, whereas others are very motivated to reduce risk of future events however they can. And so, not surprisingly, qualitative evidence shows that people who are more motivated to reduce their pill count and really want to be on as little medication as possible are more open to having the conversation about stopping statins. What's interesting is that actually applies across the spectrum of older adults. So there have been qualitative studies in people at end of life, which was conducted as part of that first trial that I talked about, and it still shows patients that prefer to keep taking statins that are still concerned about risks of stopping. So there's continues to be kind of heterogeneity in preferences, even with increasing kind of age and reducing life expectancy. So just speaks to the fact that it's important to have the conversation about preferences and interpreting kind of what matters most, along with kind of interpretations of the evidence that's available to kind of make decisions. So just in closing, I'll circle back to the peer guideline, which just came out. And as I mentioned, they recommend against stopping a statin purely because a person is over the age of 75. And I think, again, these cohort studies are pretty low certainty evidence, but given the available evidence, it seems like reasonable advice. If people are tolerating statins and are not bothered by taking the medication and they're motivated to reduce the risk of cardiovascular events, then simply being over the age of 75 doesn't necessarily mean a statin would be automatically stopped. But, like any guideline recommendation, it's about a conversation. So, during a medication review, when there's a change in health status or a sector transition, periodically reevaluating statin use, and just being mindful of the very low certainty evidence that exists, the indirect evidence that exists around statin initiation and patient preferences and goals. So again, I'm presenting my interpretation and kind of summary of the evidence, but there's plenty of time for discussion. So I'm interested to hear, what do other people think of the evidence? How do they approach this in their clinical practice, given kind of what we know and what we don't know? And I'll just kind of close by saying our group is working on a clinical practice guideline specifically related to deprescribing of statins, and hopefully that will kind of complement what's in the very excellent FEAR guideline. So, keep your eye out for that. And if you're interested in hearing more about the statin deprescribing guideline work, the contact information for our deprescribing.org group is there on the slide. And so I'll open it up for kind of questions and discussion now, because again, really interested to hear, how people are approaching this in their practice and kind of what kind of things they're thinking about in this space.
Thank you, Wade, for an excellent presentation. Again, I invite people to put their questions in the chat box and we can address them here. And to start us off, there is a question from Gregory Egan here, Wade. He asked that in that first study that you talked about where the patient was a 90-year-old female with dementia going to long-term care, when they looked at the 1-year life expectancy, did they do any analysis for primary outcome based on primary versus secondary prevention indication for statin?
No, and I think it's a great question. I think around half of the people in that trial had cardiovascular disease at baseline, but there was no sub-analysis based on primary versus secondary prevention in that trial.
I'm going to follow up that question with a question of my own, Wade. So for that same particular patient, that 90-year-old female, based on the data that you presented, but also kind of knowing that they didn't differentiate between primary and secondary prevention, would your practice be a little bit different if it was a 90-year-old who'd never had coronary artery disease before versus a 90-year-old who had a CABG and a stent and sort of, cardiac issues? How would you kind of think about approaching that?
Probably like many of us, I think like if someone has like this, has a history of a cardiovascular event, we have a little bit more pause about discontinuing. But again, I think that trial did include, half of the people did have cardiovascular disease. So I don't know that the approach would necessarily change that much. But I guess I might be drawing a little bit more from that indirect evidence, knowing that there is more evidence of benefit in secondary prevention, and probably it's a conversation to have with the family member who's involved in making decisions, to kind of understand, is the resident or the family member concerned about statins, or are they okay with continuing it? Probably, though, yeah. In my own practice, I definitely have a little bit more pause with the secondary prevention. So, but again, there's not really direct evidence to inform it. And I guess the other thing I think, which I've discussed, is that long-term care, for example, the life expectancy in long-term care is quite variable. That on average, I think it's around 2-ish years, but there's many patients who live for many years in long-term care. So I think being in long-term care alone does not, necessarily mean that a statin should be stopped either. And as I said, it is about just the conversation to find out priorities and goals of the family and the resident. And as I said, the surprise question as well is is not perfect. And I think it does it does an okay job at predicting prognosis, but it's hard to know sometimes what the life expectancy of someone's going to be. So I think that makes it tricky in that context as well.
Thank you. Yeah, that's it's not always easy decisions there. We have another question from Dr. Jim Wright. If there's any ongoing RCTs studying deprescribing statins.
Yeah, that's a good question, Dr. Wright. And I should have mentioned, so there's a trial in France that's going on right now. And I think it's primary prevention, it's called the SITE trial, SITE. And I think it's people over the age of 80 taking statins for primary prevention, and they're randomizing people to stopping or continuing. So I think it's done and it's not going to be done until like 2026. I could be wrong on that, but so there is an ongoing trial in primary prevention in particular, which I think the most kind of relevant population. And so that will clear up a lot of this uncertainty. But as I said, like these cohort studies, I did one myself, so I include myself in this bucket, is like they are, you know, a suggestion of a possible association, but they're not like definitive by any means. So, but until that trial comes out, it's kind of the best we have, coupled with kind of that indirect evidence.
That's good. It's good to know that we're going to have some more data in this in the future. We have another question from Dr. Guillaume Grenet on what is the evidence regarding the evolution of adverse event in the elderly? If there's no adverse event leading to stopping the statins in the past 10 years, for example, can we still expect a decrease in the adverse event after discontinuation?
Yeah, it's a good question. Like and when we're, as I said, we're doing a systematic review on this, or we did a systematic review on this, and we were interested in like adverse events following discontinuation, but there's no data on that. And obviously you can't really capture it using healthcare administrative data. So there's really not evidence on on whether there's any resolution of possible adverse effects or like improvement in function, things like that after stopping. That would be interesting to see, you know, whether like function or like exercise capacity and stuff like that increases following statin discontinuation. But I think it just hasn't been possible with the current forms of evidence.
Another question from Christine Batman was, any thoughts or evidence about tapering doses versus stopping suddenly for statins?
Yeah, that's another great question. And in our systematic review on this, we looked at dose reduction, but there's no studies that look at dose reduction specifically when it comes to like statin deprescribing. So that's why I guess I kind of focused on discontinuation, because that's where the evidence is. So we can't really say anything about dose reduction, unfortunately.
Another question on if you can clarify what that means in that guideline when it said do not alter statin prescribing for cognitive concerns. Do you mean not deprescribing related to cognitive issues or initiation of statins for cognitive issues?
I don't, first of all, say I don't know what they meant by that. I didn't look into that recommendation. I think that maybe what they're referring to is the suggestion that statins increase risk of modify risk of dementia, perhaps. Maybe that's what they're referring to, but I don't know with certainty.
Well, thank you, Wade, for, again, a great presentation and for answering all of these really great questions as well. Thank you, everyone, for joining, and we look forward to seeing you at our next session.
Yep, thanks, everyone. Really appreciate your time. And please reach out if you have any questions or comments.